Good evening, and thank you so much for joining us here at Medi. This is GTN TV, the home of gifts and talent. My name is Mumbi Mavuti, and today we are going to be talking about endometriosis. We are at the Kiria-Ini Mission Hospital, joined by Dr. Ratemo, who is going to be introducing himself to you, dear viewer. Thank you so much for joining us, and thank you so much for making time for us. Kindly take this moment to introduce yourself to our viewers as we introduce the topic of today.
Good evening. Welcome to Kiria-Ini Mission Hospital. My name is Dr. Wilson Ratemo. I'm an obstetrician gynecologist here in Kiria-Ini Mission Hospital and in Murang'a County.
Thank you so much. So what is endometriosis? Let's just begin right there.
So, speaking of endometriosis, it comes at a very crucial time when we are trying to create awareness about this disease with just a big name. But I want to illustrate something behind me that will simplify the big name endometriosis. So behind me is a small, nice diagram of a uterus with the fallopian tubes and the ovaries. Up there is now the rest of the abdomen, which is the intestines and everything else. So speaking of the uterus, we have a very, very special part of it, which is the inner lining of the uterus. The inner lining of the uterus will be right inside the uterus. So the interesting thing about the inner lining of the uterus is it is composed of cells that regenerate. They are basically cells that are alive. So at the end of a woman's cycle, she's going to shed that inner lining and it's going to regenerate again, grow again, and then she's going to shed it again at the end of the cycle. So basically, you shed the inner lining coming through the cervix, going into the vagina and going to the pad, all right, or the tampon. But sometimes this inner lining of the uterus tends to grow in places where it's not supposed to grow. It goes outside this cavity and grows somewhere else. So the commonest places where this inner lining goes can go to the tubes, can grow on the ovary, then it can grow anywhere else in the pelvis, cannot go all the way up to the intestines, can even go all the way to the chest cavity, can even go to the brain and other parts of the body. So basically, having this inner lining of the uterus growing where it's not supposed to grow is what we call endometriosis.
And like you said, a big name, maybe that you've really simplified right there. But how many women are suffering from this? How prevalent is it?
So I want to specifically address this locally. Locally, endometriosis is one of those conditions which we tend to underdiagnose, which basically means we have not sensitized our women enough. Our women are not looking for services in terms of, symptoms related to endometriosis. So we tend to underdiagnose the condition. So basically, the world over, it's been estimated that 1 in 10 women do suffer from this condition. But I want us to move away from those figures. I want to make it simpler and in a way that we can be able to see the magnitude of this condition. When a woman comes and complains of pain during her menses or pain in the pelvis that is not going away, almost 70% of those women have this condition. And again, when a woman comes complaining of not being able to conceive, she's been in a marriage, she's not able to conceive, up to 50% of those women have this condition. So you can clearly tell that this is a disease that is very prevalent. But in terms of local statistics, we may not have clear figures on it.
But you've painted a vivid description of how many women could be affected by the same. Now, you mentioned that most women, when they complain about period pains or cramps, they could be suffering from that condition. So now, is it normal to have cramps? Because I think most women, when they're menstruating, they complain about cramps. Is it normal? Is some level of pain expected, or should any pain signal that something could be wrong?
Well, first of all, I'd like to demystify pain during menses. Remember, we've agreed that menses are basically shading of the inner lining of the uterus. All right. So this inner lining is something that has been growing throughout the cycle, and at the end of the cycle, she's shedding because there is no pregnancy. Right. The process of shedding naturally would create certain substances within that cavity that can cause some mild pain. Again, when this uterus is contracting to release the contents of the uterus, all right, there could be some mild pain. But debilitating pain, chronic pain that is not going away, cycle after cycle, pain that limits your daily activities, going to work, going to school, pain that is accompanied by other things like vomiting, is not normal pain. So pain that is debilitating, that limits your usual day-to-day activities, is abnormal during menses.
And one should seek medical attention. Now, you happen to mention that it could go even up to the brain. Does it progress in stages, or how does endometriosis start? Will it start from the uterus, and someone will just be maybe complaining about period pain, and then it progresses? How does that come about, that you could have endometriosis growing in your intestines, or lungs, or maybe the brain?
So, of course, a lot of research has gone into this condition with a very big name. But just like we said, the inner lining has moved from here and has gone to grow somewhere else. All right? So, so how does this happen? So remember, when you're having your menses, this uterus is going to contract and push the contents through the cervix downwards, all right? But that does not happen every time. Even in women without endometriosis, some of the contents of the uterus, that is the menstrual blood, flows back through the tubes, which we also give another big name, retrograde menstruation, meaning going backwards. When it goes backwards, some of it can implant in the tube, some of it can implant on the ovaries, and the rest can implant anywhere else in the abdominal cavity, all right? So it can go all the way up to the chest cavity. But research has also shown that some of these lesions that have migrated from here have grown in places like the brain, all right, or in the lungs, and there's evidence to point that some of it might be moving in blood, and some of it can be moving in the lymphatic system, which explains why it can be growing very far away. Yeah.
Maybe when you talk about the signs and the symptoms, you're going to tell us, are the signs and symptoms the same, or do they differ depending on what part of the body or what organ is affected? But right now, let's talk about the causes and the risk factors. What causes endometriosis, and what is likely to increase one's chances of suffering from endometriosis?
So, one very interesting thing about that inner lining of the uterus is dependent on one hormone that is called estrogen. These ovaries will release, in a normal woman, will release two types of hormones. One is called estrogen, the other one is called progesterone, all right? These lesions have been shown to be dependent on estrogen, all right? So a normal woman who's producing estrogen is at a risk of developing endometriosis, all right? So what are the things that will predispose someone to getting endometriosis when someone else who is producing estrogen does not have endometriosis? So, I want to put it as simple as this. Imagine someone who is menstruating every cycle, all right, from around the age of 12 years, menstruating every cycle up to the age of around 45 without getting pregnant. Remember, when you get pregnant, there's a 9-month break when you're not menstruating. There's a 6 months after those 9 months when you're breastfeeding and there are no menses. So compare one person who's menstruating every cycle for all those years and someone else who has delivered like 3 children who takes a break from menstruating. So the one who has never conceived carried a pregnancy, who is menstruating every cycle, and that lining is being shed, some of it going backwards, is at a higher risk of developing endometriosis. So one of the biggest risk factors of endometriosis is what we call nulliparity, which is a big word that means someone who has never conceived or delivered. All right? The other risk factor, now, our children now are enjoying better diet, better lifestyle, and they are tending to get their menses way early. Menses are progressively coming down. So if you get your menses earlier than 12 years, say around 12 years, and then your menopause comes very late after 45 years, it means you've had a very long duration where you're exposed to estrogen. So very early start of menses and completing the menses a bit late, what we call late menopause. Exposure to estrogen for all those years is also a risk factor for endometriosis. One other very rare condition, but in one of those conditions where almost all of them tend to end up with endometriosis, is some children, some young girls are born with an abnormality where this tract is blocked somewhere. All right? So the tract can be blocked here, the cervix, or it can be blocked down here at the level of the vagina. All right? So every time she menstruates, all that blood accumulates either in the vagina or in the cervix. With time, once they build up all that pressure, they start menstruating backwards. All right? So that is another risk factor for endometriosis, congenital anomalies that block the outflow tract. All right? Again, now research is trying to show that there is a genetic part of it, because if in your family there's a family history of your sister or your mother having had endometriosis, you are at a higher risk of developing endometriosis. All right? So there's a genetic element to endometriosis also.
And the length of one's menstrual, the period time for one, does it influence, or does it could it cause endometriosis? We have people who have 3 days and others all the way to 7 days. Does that affect?
So remember, the normal should be anywhere between 3 to 7 days. That should be the normal. But I want us to move away from that. What is more important is this. There are people whose cycle length is, say, 28 days. And then there are people whose cycle length is, say, something like 21 days. All right? So people who menstruate more frequently with a short cycle of, say, 21 days, those people with short cycles tend to menstruate way more often than people with a very long cycle that is almost 28 to 38 days. Those people with very short cycles, because of their frequent menstruation, they tend to have a higher risk of developing this condition.
And are young girls most likely to suffer from endometriosis, or the older generation?
So, as opposed to what we used to think before, the interesting thing about endometriosis now is you can have endometriosis before the start of your menses. You can have endometriosis after menopause. So it's not dependent on your reproductive life. You can have endometriosis even before you get your first period. You can have endometriosis progressing way after menopause.
And what are the signs and symptoms, so that maybe someone does not sit down with the symptoms, assuming that this is pain that will go away, this is pain that painkillers from the chemistry can handle?
So if we were to go with this basic image right here, okay? So like we've agreed, if I have the lining of the uterus growing where it's not supposed to grow, all right? What happens is this. Basically, at the end of the cycle, all right, you're supposed to have your menses, all right? So those lesions that have grown, for example, if there's a lesion on those intestines up there, okay? When someone is receiving her menses, that lesion will be red and swollen also, behaving just like the inner lining. It's almost also wanting to menstruate wherever it is. So the symptoms will depend on where that particular lesion is. So if we start from where? Let's start from, the uterus itself. You will have severe pain, debilitating pain, the commonest symptoms are I will miss school because of the pain. I will lie in bed the whole day because of the pain. I will miss work frequently because of the pain. All right. All right. So when you start with the uterus itself, that is one of the commonest symptoms, debilitating pain that does not go away. But this pain can be accompanied by other factors. For example, if the lesion is on the tube, you will have pain that is either centralized, somewhere in the middle, okay, or the pain can be on the left or on the right side. All right, okay. So when this lesion comes to the ovary, then what happens? In the ovary, it's more interesting because in the ovary, it can form small pimple-like lesions, or it can form a whole mass. All right. So someone can come complaining of a swelling on one side of the abdomen when that lesion goes to either side of the ovaries. Okay. But like we said, these lesions can go anywhere else. So if they go somewhere else, what would you have? Like if they go behind the uterus, all right? If they're behind the uterus, one of the commonest symptoms a patient will present with is, when they get intimate with their partners, there will be severe deep-seated pain. That means the lesions have come somewhere behind the uterus, all right? These lesions can also migrate from here and go to the intestines. When they go to the intestines, what happens? You can get severe abdominal pain that is not in the lower pelvis, anywhere else. You can get diarrhea. You can get pain when going for long call. You can get blood in stool. You can get diarrhea, right? You can get constipation, all right? Then this lesion also can migrate, can go, say, where? Can come all the way to the chest cavity. When it gets to the chest cavity, of course, you'll start having a certain type of cough. And more frequently, this cough will come at around the time you're having your menses. This cough may be accompanied with blood, right? There will be difficulty in breathing sometimes, all right? Sometimes they can even have masses in the lungs. They can have some fluid accumulating in the lungs. And in the unfortunate event that it progresses further and goes, say, to the brain, then you will start having, when you have your periods, you start getting these convulsions, loss of consciousness, severe headache, vomiting, And then if it affects the spinal cord, then you can get weaknesses in either the hands, or the limbs, the lower limbs, all right? So depending on where this lesion goes, the symptoms will accompany that body part.
And in case for someone who already has the condition during their menses, are they likely to see changes, like maybe the bleeding is heavier than normal, which may be little?
So, where apart from just the pain, when they get menses, something is likely to happen. This uterus usually has a way of controlling its own, amount of blood that it loses. But in people with endometriosis, because of all these effects of this disease and their bodies releasing different substances, their uterus may fail to contract very well when they're getting their menses. So they may end up with more than normal amount of bleeding. If it was lasting 3 days, can go to 7 days, or in that one day, when they used to, change pads 3 times, they can go up to 5 times, which indicates that you're bleeding more, all right? And then again, this condition can sometimes result in bleeding that comes when it's not expected, what we call intermenstrual bleeding coming in between your cycle. Yes.
Thank you so much. We're going to be taking a short, quick break right here at Medi Camp, and when we come back, going to be talking about the complications that one is to expect if they suffer from endometriosis, and the diagnosis and treatment, and much more. Keep it right here.
We are putting certainty in their future so you can have a peaceful life. Exploring emerging opportunities so you can explore life. Covering your health so you can share your well-being with others. Taking care of your investments so you can enjoy the fruits of your wise decisions. With Britam, we are assured of over 55 years experience in life insurance, health insurance, general insurance, investments, and retirement solutions. Britam, with you every step of the way.
RBG Engineering Limited is an engineering company that specializes in fabrication and forming projects involving stainless steel, mild steel, and aluminum, and is committed to quality, reliability, and cutting-edge technology. Our services include metal folding, metal cutting, architectural steelwork, on-site services, while ensuring we collaborate with our clients from the initial idea stage, developing the concepts and translating them into computer-aided designs. For more information, contact 0738 123 123 or visit our offices in Kingongo, opposite Shell Petrol Station along the Nyeri-Nyahururu Highway. RBG Engineering Limited, building the future.
God found me a woman, my woman, my priority. She fell in love with the wild.
Wendo ni kiheo na ningĩ nĩ rĩathani, na nĩkĩo gũkũ kwa GTN TV twĩharĩirie tũihũrĩtwo nĩ wendo mũingĩ gũkũrehera magongona mothe mahutanĩtie na kiugo wendo. Tukanjĩrĩra na kũhanda ithĩgĩ, tugathiĩ ũthoni, tukarenga kĩande na gatũrũ kohoro tugakũrehera mohiki ma kĩrĩu, ma gĩkũrinũ na ma kĩndũire. Nyitanĩra na niĩ wa njĩra wa mũthe o mũthenya wa kiumia kuma thinacara nginya thaa 1 cia hwaĩ-inĩ. GTN TV, mũciĩ wa iheo na taranda.
Thank you so much for staying tuned here at Medicamp. Today we are learning about endometriosis, a condition that is affecting quite a number of our women in our society. And right now we want to talk about diagnosis. How is diagnosis done, since one could assume that this is pain that will go away, this is pain that I'm going to cure with some Panadols. So how is diagnosis done, and then maybe what does treatment entail?
So like we had discussed before, in Kenya, this is one of the conditions that we tend to underdiagnose, all right? So that already tells you that the diagnosis of endometriosis is not as straightforward as we used to think before. So when it comes to diagnosis of endometriosis, there's a special term that we use. We call it presumptive diagnosis, where the doctor sits with you, listens to your history, does a physical examination, examines your abdomen, examines you in your examines your pelvis, and then they can actually, from just that, they can make a diagnosis of endometriosis. That is what we call a presumptive diagnosis. A presumptive diagnosis is based on your history. Someone comes to you and tells you, I have this chronic pain in my lower abdomen. During my menses, I have this severe debilitating pain. They can also be accompanied by other symptoms. I have blood in urine. When I go to the washroom for short call or long call during my menses, it's extremely painful. I have this constipation. I have this headache. You could examine the patient, and make a presumptive diagnosis of endometriosis. The advantage of making a presumptive diagnosis is that we tend not to delay treatment. Because, like I said, remember, this is a condition that sometimes can be very progressive. So the earlier you make the diagnosis and start someone on treatment, the better it is for them. All right? So presumptive diagnosis is one of the key things when it comes to diagnosing endometriosis. All right? So apart from that, what else can a doctor do? Remember, when I'm examining you, I'm looking for, where is the pain exactly? Is it on the right side? Is it on the left side of the abdomen? Is the pain behind the uterus? Is the pain centered around the ovaries? Is the pain centered in the intestines? Is the pain, coming from the chest? I want to listen to that chest. is the headache associated with other symptoms, in the brain? So there are things we examine for that can tell us, yes, we may be dealing with a lesion in these areas, and we can make a diagnosis of endometriosis. But apart from that, there are things that we can do. There are imaging modalities that we can use to be able to say that this is endometriosis. But before we talk about what I will see on imaging, what do I see when I examine a patient? What is it that I'm likely to see? One of the things that you find when examining their abdomen is sometimes around the navel, which we call the umbilicus. Sometimes you may find a mass or a nodule. That mass may be discharging some chocolate-like substance, or the patient may tell you that during my menses, actually there's some blood coming out of my navel. That is actually one of the signs that brings people to hospital. Apart from the chronic pain that people tend to assume is normal, blood coming out of the umbilicus or a mass in the umbilicus that is extremely painful during their periods is what brings them to hospital. So when you're examining the abdomen, you may find a mass in the navel, you may find a mass anywhere else in the abdomen, or you may find severe pain when you touch the abdomen. That can be a guiding factor to know where the pain is, all right? And that can tell you where the lesion is growing, okay? So apart from that, we also have, technology has given us the advantage of things like ultrasound. So ultrasound is, a small computer that you find in the imaging department with something like a torch that is placed on your abdomen. The doctor applies some gel and then places that torch on the abdomen, and then they can see the images on a screen. That's called an ultrasound, all right? The ultrasound can show us, any organ in the abdomen, the uterus, the ovaries, the intestines. But for endometriosis, we do a special type of ultrasound. This ultrasound has a torch, special torch that goes through the vagina, all right, and settles somewhere here so that we can clearly see the ovaries a bit closer, all right? That type of ultrasound is called a transvaginal ultrasound, all right? And it's not in all circumstances where I can be able to do a transvaginal ultrasound, all right? In circumstances where it's inappropriate or you can't just do that ultrasound, you can place the torch in the perineum, just outside the vagina. It's easier for you to see the ovaries and the uterus, and you can see the lesions growing in areas around the pelvis. That's called a transperineal ultrasound, all right? So an ultrasound, a basic test, which is not expensive, can actually diagnose endometriosis, right? But we don't rely on that. We rely on history and physical examination, all right? Apart from that, there is a more expensive test, all right? But I think it's now available in so many centers. It's called an MRI. An MRI is a very detailed imaging modality that can show us where these lesions that have left the uterus, are they growing on the ovary? What are their sizes? Have they gone to the intestines, and which part of the intestines? Have they come up all the way to the chest? Where exactly? So an MRI is one of the higher end imaging modalities that can specifically define the lesions, tell you their number, every fine detail. Right? So basically that's what we use now to diagnose endometriosis. But put all that aside. Endometriosis is best diagnosed surgically, all right? Surgically, by this we just basically mean we want to go into the abdomen and see, all right? We want to go into your abdomen and see, all right? So how do we get into the abdomen? We do not have to do surgery for us to be able to see. There is a very minimally invasive technique called laparoscopy. Laparoscopy is a technique where a camera goes into your abdomen with a very tiny, incision on your abdomen. The camera goes in, all right? And the camera can look around this area, can tell you where the lesions are, how many are they, can look all the way up to the end of the abdomen, up here where we have a covering called the diaphragm. So it looks for all those lesions everywhere, all right? And that is one of the best ways of diagnosing endometriosis. The advantage with laparoscopy is we can diagnose and we can treat at the same time.
Beautiful, beautiful. And when we base the diagnosis on history, is it possible maybe to confuse endometriosis for another condition maybe?
You know, when you do presumptive diagnosis, one of the risks that you're taking is you may be treating it as endometriosis, yet we have a different type of condition that is causing, the chronic pain. So basically one of the conditions that will cause chronic pain in the pelvis, which is also considered together with endometriosis, is adenomyosis, which is totally different. But it's actually easier. Just means this inner lining of the uterus is growing in the muscle tissue of the uterus. Can also cause severe debilitating pain. All right. And there are other conditions that can also occur, and they may mimic the same symptoms of endometriosis. Like for example, if you had an infection in the tubes, you'll have the same chronic debilitating pain. Infection in the ovaries or a cancer growing somewhere in the ovaries will cause the same, all right? When you have something like hemorrhoids here in the intestines, all right? The last part of the intestines, you can get pain when passing stool and blood when passing stool. That may mimic endometriosis. So when we make a presumptive diagnosis, one of the risks we take is treating it as endometriosis when it's something totally different.
And is endometriosis curable?
So the interesting thing about endometriosis is in a certain percentage of women, almost I think 5% of women, the condition has been shown to just disappear on its own. No treatment, the condition has been shown to disappear. But failure to treat endometriosis, like I've explained, can be very debilitating. It can cause a lot of harm in the pelvis, the abdomen, and elsewhere in the body. All right? So treatment of endometriosis, especially early treatment when the disease is in the early stages, is key. Treatment of endometriosis is very interesting because, remember you're dealing with a lot of a group of symptoms, a constellation of symptoms. You're dealing with pain, you can be dealing with a mass, So treatment basically is dependent on what we are dealing with. But let's start in the basics where someone just has the chronic pain during menses or in between menses. So, of course, if I'm dealing with pain, I would like to address the pain, all right? So when addressing pain in endometriosis, we prefer to do it in a systematic manner so that we don't just throw in any drug, all right? So we may start with very mild drugs, then we step up the ladder, right? So your doctor will probably, after diagnosis and, they've seen this is still mild, they may start with something as mild as, paracetamol, all right, during your menses, and extend it a few days after your menses, all right? Then if it's not working, your doctor may move up to something like what we call non-steroidal anti-inflammatory drugs, NSAIDs, okay? These are drugs that are in a certain class. They have better ability to cure pain, all right, with not so bad side effects, all right? So they start down there from maybe paracetamol, then we can move up to the NSAIDs. NSAIDs have been shown to work very well with endometriosis because they have, apart from just curing the pain, they have an anti-inflammatory effect. These lesions, if this lesion lives here and comes and settles in the intestine, it will cause certain effects around that intestine because the body is reacting to it. So NSAIDs can lessen the body's reaction to that lesion, and that is why we prefer NSAIDs, to other types of drugs. If that fails, then your doctor will go to step number 3. Step number 3 is where now, remember, we agreed that these lesions are estrogen dependent. They depend on estrogen. And estrogen is released from the ovaries, all right? So then the doctor can give you something to tell these ovaries, I don't want too much estrogen, all right? So those drugs are called hormonal drugs, all right? So they may give you a drug that counteracts the effects of estrogen, called progesterones, all right? Or they may give you something as simple as the normal Femiplan, all right? Femiplan is a combination of two hormones, estrogen and progesterone, all right? They have been shown to reduce the amount of estrogen that the ovaries, the amount of endogenous estrogen being produced by your ovaries. That way, we lessen the symptoms of endometriosis. If that fails to work, we can go higher up. We can tell the brain, please tell these ovaries not to release estrogen. We can do that. There's a drug we can give to tell the brain to tell these ovaries to quiet down, release less estrogen. Those are the mainstay drugs currently. So your doctor may give them a very long name. They're called gonadotropin releasing hormone agonists and antagonists. Forget the long name. We're just telling the brain to tell these ovaries to be quiet. All right? Yeah. So now the world is moving to those drugs, but with less side effects. All right? Yeah. And at this point, I also want to mention that drugs that tell the brain to tell the ovaries to quiet down can have some serious side effects that can mimic menopause, some of them including bone density loss, and you can get fractures, all right? You can get symptoms of, menopause itself, all right? Yeah. So those are some of the things now the world is working on to reduce the side effects of those drugs so that we can get a drug that is, well suited for our women.
And is at any point surgery an option for treatment?
Good. So now, you see, we've discussed what I can give. So I've given you pain drugs, I've given you hormonal manipulation. But during my laparoscopy, I see a very big lesion here, all right? Or I see a very big lesion lying on the uterus. I see a big lesion lying somewhere, like on the liver. Another lesion lying on the diaphragm. What happens? Are we going to give drugs alone, hoping that it will go away? So some of these lesions are so big that they create certain symptoms that are because of the lesion itself, having a mass there. For example, if I had a large cyst on the ovary, all right? This large cyst, no matter how much of this hormonal manipulation I do, the mass may never go away, or the mass may just be having a mass effect, pressure effect. So surgery is an option. But at this point, I want to be very, very, very clear that, one, removal of, say, the gonads, the ovaries, is not going to cure a lesion that is already on the intestine, is not going to cure a lesion that is already on the diaphragm. No. So removal of the ovaries does not cure your endometriosis. All right? So what we do is, yes, we will boost you up with medical treatment, which means, the drugs we've talked about. But then surgery is very important because a lesion sitting somewhere, the body is reacting to it. It can cause some severe debilitating effects. All right. So removal of the lesions is very important. All right. So the lesions are removed better laparoscopically. If it's on the intestine, it's removed. If it's on the ovary, it's removed. All right. If it's somewhere else, it's removed. You excise those lesions and you support the patient with medical treatment. That reduces their symptoms or even cures them.
I don't know if this is a myth. Maybe you can help us get the details. Does getting pregnant help in making endometriosis go away?
I want to answer this question with a small illustration of a 14-year-old who came to our clinic here in Kiria-Ini Mission Hospital with clear symptoms of endometriosis. Pain, she doesn't go to school. Of course, by the time she's been brought to me, she's at loggerheads with the father. Father thinks she doesn't want to go to school. She's just being naughty. Someone counseled them and told them that when she grows up and gets pregnant, these symptoms will go away. So in the parent's mind, they think that this debilitating condition can go away if this girl gets pregnant. You can imagine the dilemma that puts a parent in. I want to be very clear that pregnancy may quieten the symptoms at that point when you're pregnant. But once the pregnancy is over, the symptoms will come back. So pregnancy should never be prescribed as a treatment for endometriosis. It is not.
Thank you so much for clarifying that. And now, in case someone takes a long or it may be delays in getting treatment, what complications do they risk getting?
So, delay in seeking treatment for endometriosis, I just want to start from the simplest part. Imagine having pain from the age of 12 years. You've not, sought any sort of treatment. You are now 25 years. You've had 13 years of debilitating chronic pain every cycle. So these are people who will come to you with mood disorders. They may have just a low mood. They may go all the way to the level of depression because of the debilitating pain. Yeah. So one of the conditions that, is associated with endometriosis is a mood disorder. All right. Now, apart from that, now let's come back to physically what it can cause. All right. This is a patient who is literally going not to be able to get intimate with their partner, because if there are lesions behind the uterus, anytime they get intimate, it's going to be severely painful. So you can imagine the kind of, disharmony. If it's she's in a marital disharmony. Again, these lesions, like I said, they create certain effects where they are. So imagine a lesion that are settled here between the ovary and the tube. What is it going to do? It's going to close the tube, twist the tube, and clamp the ovary and the tube together into a mass. All right? So imagine that happening on both sides. This is a patient who is, getting into a marriage, for example. She wants to get children. Both tubes are blocked. All right? So she'll come to you with infertility. That is one of the other complications of this condition. All right? Now imagine this lesion has gone where? Has come to the intestine, especially the lower part of the intestine. All right? It's a huge lesion eating up the wall like this. It can create a perforation. When you get a perforation in the intestines, that is already a life-threatening condition now. You can get what we call peritonitis. All right? You can get necrosis of the whole intestine. All right? Not treated, this condition, like we said, can go, imagine lesions coming up to the chest. All right? So what happens in the chest is the lungs are very soft tissues. All right? When you have a lesion growing in the lungs, difficulty in breathing, coughing blood, you start getting accumulation of fluid in the lungs. And later, the lungs undergo what we call fibrosis. Fibrosis is just a long-term, meaning the lungs can collapse and form a very hard mass. So you can't breathe. All right? Then this lesion can go to the spinal cord. The spinal cord can cause paralysis, lower limb or upper limbs. All right? And it can go to the brain and give you a chronic condition where you convulse continuously, convulsions continuously can also, impact your lifestyle. You cannot be productive. All right? So those are some of the complications of endometriosis. But top on the list is usually endometriosis is associated with infertility. Almost 70% of the women, usually those tubes have been affected.
And when the fallopian tubes have been affected, maybe due to endometriosis, are there ways that such a woman can be helped to maybe conceive?
So when we get these tubes blocked, it depends on what is the level of blockage. All right? We have imaging modalities where we can assess the tubes. All right? But most importantly, you have to have known that she has endometriosis, started on treatment for the endometriosis. Then we can deal with the tubes. So basically, sometimes you find the blockages at the end. So laparoscopically again, you can open that end, and the tubes may come back alive and, she can get pregnant. All right? But delays in treatment, these tubes usually affected permanently because, they affected the whole length. All right? So they tend to close the whole way. All right? Yeah. So delay in treatment can be very devastating for those tubes. Yeah.
There is really need for us to keep creating awareness on endometriosis because the complications associated with the conditions are quite dire. Now, before we conclude, is it possible to prevent endometriosis?
Well, first of all, I like we agreed, we do not encourage pregnancy as a method of, of preventing endometriosis. And remember, like we said, part of this condition is genetic. All right. So the most important thing when it comes to endometriosis, say prevention of the debilitating stages of endometriosis, is early diagnosis, early treatment. Do not delay starting treatment when you make your presumptive diagnosis. Because some of the drugs that we use when we make a presumptive diagnosis, the ones we discussed, are harmless. They are harmless. So prevention for me is just prevent the chronic part of it, then you'll be okay. But prevention in terms of complete prevention, maybe research will show a few things, but not something we can, pinpoint and say, this is what you do to prevent endometriosis.
Thank you so much for that. That has been quite an enlightening episode here on Medicamp. Maybe before we wrap up, maybe you have a call for our women, and what would you tell them so that we can make sure that diagnosis is done in time, and so is treatment to prevent the complications that come with delayed treatment?
So, and I would like, a situation where endometriosis is handled by society. This is a condition that, yes, affects our women. It affects our sisters, our wives, our mothers. But it's a condition that will impact on society. So I want to encourage our men to participate and be supportive, encourage any woman who has debilitating pain during their menses, encourage them to seek care early enough. You'd rather come, we find, the cause. If it ends up not being endometriosis, well and good. If it ends up being endometriosis, remember, like we agreed, early treatment is what prevents all these other complications. So I want to emphasize on early treatment. So that young girl going to school who, during their menstrual part of their cycle, they have debilitating pain, they don't want to go to school. It's not the girl being naughty. It's a condition that you need to bring her to hospital for us to be able to make a diagnosis and treat her early.
Thank you so much for helping us create awareness on that. This has been the Medicamp Health Show. My name is Mumbi Mavuti, and remember that your health is your wealth, and there isn't a magic bullet for health. You have to live healthy and be healthy. See you next Tuesday in yet another episode of the Medicamp Health Show. Keep it GTN TV.
Thank you.
We are putting certainty in their future so you can have a peaceful life. Exploring emerging opportunities